Thanks for joining us tonight. My name is Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns, in far north Queensland, and tonight is my great pleasure to invite Kerry Stingel, hand therapist extraordinaire, who has been working in Cairns for 25 years. We're going to have a celebration very soon of that anniversary, and tonight she's going to teach us everything we're going to ever need to know about post-operative edema management. Thank you.
Thank you, Sarah. So yeah, when I was asked what topic I wanted to present, I thought, well, look, that's really common, that there's going to be some swelling after surgeons cut things. So I thought it applies equally to arms and legs, so that we would kind of touch on both. So
Excellent.
let's look. So my aim is to be fairly practical, give you an idea of what can be helpful and why we need to manage it more importantly, so that we're not seeing the unintended consequences of unmanaged edema. So, firstly, edema is swelling. So just so we're really clear, it's the same thing. And that swelling occurs when we're injured. It's a natural part of the process, and that the problem comes when it gets stuck and it kind of just hangs out in that one area. So I often use the analogy of the swelling being the lymphatic fluid just normally being like a river, rushing on by, and it's nice and thin, and it moves in and out of the area appropriately, versus when it gets a bit stuck, particularly because maybe it's a dependent arm, it's hanging down, or the leg is down, and there's fluid coming down, it turns into a swamp. And so I'll often say to the patients, oh, you've got swamp arm, and then make sure they understand that, you know, this is, I'm joking, but it kind of is just like the picture of, instead of being a nice clear riverbank and everything rushing on by, it's sort of gone off into a swampy billabongy area. Things fall in it, leaves and tree trunks and stuff, congests up, it gets thicker and stodgier, and then the fluid has trouble getting out. And so part of our job is to get that process freer so that the flow gets back again and it can resume its normal stuff. And I think the analogy works really well, because no one wants to have a swamp. So, and the other analogy I use is that edema is, when it limits movement, it leads to a loss of, the stresses that normally apply to those structures is deprived. So that then leads to sort of building of bonds and cross-linkages of things that aren't meant to be linked. So it's that swampiness concept, and I often talk about that, or I'm starting to talk about that as like a hose that's a bit flexible. Things should be flexible, not a pipe, so that's rigid and stuff. So early intervention is definitely critical. So we want to get in there early. We want to do stuff that's going to manage things so that it doesn't get congested, and we want to throw everything at it that we can so that it's not getting stiffer than it needs to, it's not getting more painful. With more swelling will also come more discomfort. We also want to make sure there is adequate pain control, because if it is painful, the brain says, oh, you're hurt, let me send you more fluid to help heal you. And then it gets more fluid and more lymphatic fluid stuff. So we want to definitely start early mobilisation. So if it's hand, I'll probably use hands as most of my examples, because it's much easier than showing my knee. And the hand, if it works on the hand, it's going to work on the ankle and the knee and everything else as well, because the hand is much more tricky. So we want to mobilise things at an appropriate pace. So we don't want to be mobilising something that should not be mobilised. So if it's had a tendon repair, there's a very cautious amount of mobilising that we need. If it's got a broken bone and it's then got a plate in it, then we can probably do a certain amount of mobilising without risk. But we always defer back to the surgeon, sort of giving us an indication of, yep, it's pretty strong, or it's more really fragile, or there's some bits that aren't so great. Yeah. And we definitely want to avoid that flare reaction that can happen. A classic example occurs in the Dupuytren's release people, that they want to get going too quickly and the inflammatory process kicks in, and then they end up way more problematic because they've been pushed too hard. So we definitely want to stop them ending up with a broken wing. So it's called broken wing syndrome, because they've kind of got it here and they're very protective, and when their arm won't come out there to do things or hold their phone or whatever, if that's an appropriate thing for them to be doing, then that's a good cue that that's not good. We need to encourage them and educate them about being safe to do that. So it is interesting that, sometimes years after their injury, people will still be going, I can't do heavy things with this hand. I'm going, why not? Oh, because I had a tendon injury 15 years ago. It's like, hang on, the instruction on being careful with it was 15 years ago and probably should have lasted no more than 3 months, so that confidence that they can tell their brain that this is actually safe to move, it was really important. So we had a recent example of that, which was amazing. So when Oedema is present, we have these very different changes in the pressures in the vessels, and it allows leaking of fluid outside the vessels. And so external compression, which opposes that force, is often important to the resorption of the fluid. But the care needs to be taken, particularly if vascular structures were involved in the repair. And often you'll tell us things like, the surgeon will tell us things like that there was a radial, digital, arterial nerve, usually at the same time injured or repaired, or sometimes not repaired.
Yep.
So, and so we want to be very sure that any form of compression is not constrictive, and so it's very important that we get that right. So I've just got some pictures. I'm sorry for anyone who's squeamish.
These already. I was squeamish. It's all right.
And, you can just shut your eyes and go, la la la. But these are just some examples of. So the top picture, actually, there is no wound. There was no surgery. It was a crush injury, from a very long time ago, where the hand was on a railing and a cow pushed the cattle crush onto it, and so it was an immobile force, and the poor hand got squished in the middle. So you can see the difference in the swelling. But it just required really good bandaging in order to manage that. So we couldn't go to a compression wipe on that straight away because it wouldn't have fitted very well into anything. And it just needed a lot of that fairly soft fluid at that point to move on first. As well as starting very gentle mobilisation. Fortunately, there was no broken bones. How astounding is that? But the risk with a crush is that there's often significantly more stiffness created because all of the structures held the force for longer. Whereas if it's, say, broken something, the force is then dissipated. So you think about bending a green stick, a stick you pull off a live tree, you can actually put a whole bunch of force into that before it actually does anything, or it might not even break, versus a dead, dry stick that's going to just snap fairly easily and the force dissipates, versus when the force has remained in there, there's a lot more stiffness. So it's very, very important to get compression management, otherwise the swamp takes over. Also a long time ago, so these are
very old, that one.
Actually, these are actually hard copy photos before digital cameras. This was not the scariest day. This was several days after the scariest day, and this was not immediately after the injury, but this was some weeks after the injury because of the nature of how this person got injured, and someone forgot to stop her blood thinners. And so I remember not even being comfortable asking could I take a photo in the early days, because it was just scary.
Is that after surgery or
after surgery?
Had a little bit of surgery.
Yeah, she had a so much bleeding.
That's why we stopped blood thinners.
Mm-hmm.
That's why I keep talking about it.
5 days prior to start shooting blood.
Yeah, and there may have been medical reasons why that wasn't done.
Yes, of course, sometimes.
But I'm not
significant
certain that's
sometimes
the case.
If it's multi
Because it was so far down the track from, I just thought, this is a bit unforgivable, or at least someone should have warned us. So, anyway. So these are some more common ones that we might see. So this was very much a delayed union, possibly related to the patient being a very big smoker, and there was a lot of swelling hanging out there as well, and managing just even a single finger was really important. And the classic after a distal radius fracture, and different looks about things at different times. But we'll talk a little bit about one of the things that really helps is the sooner we can get the wound healed, the less swelling there will be coming to the site. So, because the brain really wants, the body really wants our help to heal. So it's going to do all its things. It's going to say, oh look, have some fluid, it'll help you heal. And I often have had this little cartoon in my brain of, let's come and help, and they all run in and help. And there's actually an anime cartoon that does exist exactly this. It's hilarious.
To explain it.
Yep. Okay, so this is another one. Sorry again.
This is the one that mentions it.
This is a dehiscence of a wound that there's a lot of tension often on terminalisation of so keeping the pressure off that wound is really, really important because otherwise it just wants to stretch apart. And so this was a fantastic job that we all did after much energy and wound healing. Once it was healed,
What sort of product is that?
devised a lycra sleeve. So using the lycra that we make normally in a little sleeve that we normally just have on, a single digit.
We found that because the stuff was so short, a standard sleeve will just fall off. So we wanted to encourage keep it on.
So you needed to anchor it on the side of the hand.
And it goes down the other side as well. So
Down the front.
Yeah, so that's worked beautifully.
Really?
well done. Should patent that.
Should present that. But then we'd have to share our Ruby, who is the expert sewer.
Yes. So she made it for you. Yes.
So various other, this is actually a sequence of one person as it's healing and the terminalisation, rehabilitation. And these things can take a lot longer than you really want to heal. It's really amazing. So I think surgeons usually try and make sure you've got really good viable tissues and good coverage and all the rest and reasonable shaping and enough padding, otherwise you end up with real problems with hypersensitivity and neuromas and things. But I'm not sure of the timeline on that one.
That one took about 6 weeks to close, and as a non-smoker.
Wow.
It took a long time.
It depends on, so sometimes you're trying to preserve the ability to flex the FDP, so sometimes you leave a little bit of length to keep that. It depends on what, and also when it's acutely injured, it's really takes a lot of experience to judge whether or not that tissue is going to survive down the track. And as you know, looking, is this bit going to survive? Is this bit going to survive? To yourselves when you get these wounds when they're fresh, you can't predict what it's going to take.
And we need to be extra attentive to the wound care in Far North Queensland with humidity and people thinking they need to wash their hands all the time and putting their hands in places they shouldn't and getting dressings wet and things. So good education about wound care and things like that. So I'll show you some feet.
There was the thumb.
Let's see. Oh, your thumb. So there's a nice thumb that is just closed, almost closed. So one of the other things I constantly stress is fully closed and and robust before we stop dressing. So one of the surgeons I used to work with a lot used to talk about wounds had to be robust before you stop putting dressings on, not just closed.
Okay.
Because of the shear of things on the skin. So particularly on, say, the volar surface of a digit, there's going to be more rubbing and more compression there from everything they do, particularly a thumb. So we would have kept that dressed. We might have put a lycra sleeve on then. We might have used a silpos sleeve, which the silicone jelly stuff in it. And it does. This is a fairly small one. There's a bigger size, and that works really quite well on long enough digits. And we want to watch for things like a little bit of hypergranulation, so where we've got a lot more red, meaty, bleedy tissue coming out, not skin coming over. We really want to make sure that's dressed appropriately, and sometimes touching that up with a little bit of silver nitrate so that it cauterizes it and stops it.
Does the patient tell you if the dressing is too tight? How do they describe that? Does that make sense?
Too tight.
How do you know? How do you know? Like, you can feel it as you're putting it on.
Yes, it's very important as we're putting it on that we know which product we're using and how to go too tight. So one of the things with actually I can put my toilets there is that way we're
Alright, go on.
Can I do that?
Yeah.
So when we're putting, say, Hennigal's cohesive on, so if we were putting it on maximum stretch, that would be definitely too tight. So we would only ever put it on a tiny bit stretch, but not no stretch. So if I was to put it on no stretch, you can look at
Just
just stupid and just fall off.
Yes.
Yeah. So we want to be really, really attentive to just a bit of stretch and not getting it there and then pulling it and placing it. So we want to release a bit and then place the next bit, and being sure you're doing like
Something to stabilise it
a
before you
50% overlap and being really, really definitive with where we're placing it so that it's not kind of here and not got two layers there.
to make sure that pressure's going to be consistent.
Yeah, and always start distally and move proximally because that's the way the fluid's got to go. There's no tap on the end of the finger. So if they, yes, they can feel that it's too tight. Sometimes
It's still moving.
absolutely. So I often say to the patients, students fully bandage my hand as part of their training. They have to. That's what I make them do. And with a fully bandaged hand, I can still make a tight fist. So when you're thinking that you can't do what you need to do, it's because you've got an injured finger, not because I put a bandage on it. So what people often describe is after, particularly if they're not actually able to move very much because, say, a tendon injury or something like that, or it's really, really sore, is that they will always check the capillary return. We'll be looking for it being nice and pink, pink being a very good colour for a finger, blue never being a good colour for a finger. So very, very occasionally we've actually taken full sets of bandages off and redone them because it's just not been right. Or that it may have vascular structure injured, so we've had to be super careful. Yeah, or but they'll often feel throbbing, and that's appropriate because if you have a vessel sending fluid in there and then you put something against it, it's going to feel the throbbing, whereas we don't normally feel the throbbing because there's nothing there to resist it. If that, and I say, if that doesn't go away or if that becomes more unpleasant, then let us know.
Okay.
Yeah, does that answer that?
Yep.
Have you had problems with any people who?
No, I've always been curious about whether or not I was getting the tension right on things like Coban.
Yeah, so Coban,
and I'm frequently putting dressings on when people are asleep.
yeah.
So I've been anaesthetised with local anaesthetic. So there's no way to get any feedback other than
But they don't really know, so they're not a good reliable indicator, so it's fine. You can do it when they're asleep as long as you know your product. So
I know this product feels different to what we've got, which is that one.
yes, so Hennigal's adhesive is really good. I would just about never dress something early post-op with Coban.
Okay.
Because
this is a lighter.
The risk of putting it on too tight
It's higher.
is much higher.
Right.
And in that width, because you can crank it up, you've got to be careful.
It's sort
not
of
to crank it up.
tourniquet.
Yeah,
Because
yeah.
it's so narrow. Yep.
Yes, so when we use Coban, we will usually use it in this width or 3-inch, just 3-inch or 4-inch wide and do a single wrap. So we do that and then put a little V in the bottom and then come back with finger again.
Yes.
So put the little V down your palm side and pinch it together. So you really can't, so if I tried really hard to crank up the tension of this, which you wouldn't do post-op, I wouldn't do in the theatre, I wouldn't think. Partly because you're going to have dressings and things that, unless they were on here, you might. And then, but days after that, we would often do that. And we just trim off the dorsal fin here. And then fold that down so that it kind of
Very fun with Queensland.
Yeah. Now that's the tightest. I wouldn't even do that normally, but does that?
But I can still move it.
Yes, yes. And so that's really important. We want the dressings to be and the compression to be as minimised as possible, but still effective, so that it's managing the swelling but not restricting the movement. So And if it was like if you were restricted because you just had a big cut put on fixed here, then you should still be able to passively range it with the compression. Or that you might be a bit of a bulky dressing because it might be a risk of bleeding. But then it comes back to the choice of dressing so that it's minimised. So we wouldn't use lots of gauze. We would use Primapore and things that Melon and stuff like that because they're too bulky. So often we'll use and some of our favourites, which I was going to get onto later, but to get down to it, is Supersalt P. This may be a little bulky, but sometimes if we want it to be very absorbent, that's what we want. And later on, when it is just that like this, it means protecting. Supersalt H, which is just like another skin, is really flexible and lovely and cheap compared to many other things. So of course we also love Mepilex and Mepilex Light, Border Flex and all of those Mepilex ones, which are not,
You put them in the hospital.
not cheap, yes. So, yeah.
I like that one. That's a nice one.
So, early days we might suggest they be using cold packs to reduce the swelling and to help with pain management, but just monitor it, and it's usually only effective in the first 3 or 4 days anyway. So, and for about 10 minutes at a time. So that's what we'd often suggest, whereas people kind of can leave them on way too long. We don't want it to go from that cold feeling to the burning feeling, because that can be problematic. So, and we want to encourage them to elevate. So we want their hand above their elbow and their elbow above their heart. So up on pillows, not in a sling. Because if they start in the sling, they get a broken wing, and so often they are just perfectly fine because they're probably sitting watching television. So then encourage them to grab pillows, to prop their arm up, and to move the uninjured joints. So we want to be moving the elbow, if it's only the hand, or if it's the ankle, we want to be moving the knee, moving the hip, so they're not just going really stiff. Of course, we want to be careful not to elevate something that should not be elevated. So a graft or a flap may be the exception to that. And so then they have different protocols to that. Which really amuses me, the names of often those, is that you start on just the drop and dangle for a minute. So that means you're allowed to lower the leg on over the side of the bed and leave it there for a minute.
The drop and dangle.
Yep, sounds like it should be a dance. Yeah. But anyway, they're much more complicated and often still in hospital at that point when you're working through that. So that may be the exception, is that we wouldn't necessarily elevate a flap. You don't see a lot of flaps on hands.
No, because it's hard with the tendons, the flexor and extensor tendons. It's hard to.
Yeah. One of my favourite ones was a cross finger flap where the person had a bit of darker hair here that's then swung over, and so then they had a very calm.
Oh, really? They treat it with laser. You can have laser hair removal.
Yes. She was rough and tumble, so she was just fine. But it was quite funny.
You have to be very careful because the patient presents to theatre shaved.
Yeah.
So you don't see the hair. And then if you,
My dad's got a skin graft on his nose and never his hair.
we'll get it laser.
Yeah. I'm gonna tell him that he doesn't care. He's got ear hair too, so yes.
There's a point where you kind of just go,
whatever. He's totally past that point.
Now I'm going to notice when I'm leaving.
Yeah.
You will be very distracting.
You will.
just let me trim that for you. So this is a leg, obviously, and just sort of, we don't collect lots of pictures of legs over. You treat a lot of swollen legs with wounds, but I believe there's a suture line there that has had trouble healing, and we know that legs have a lot of trouble getting wounds healed if they're swelling, and they do much better when we manage the swelling, and particularly if the wound is near the ankle and they just had a bandage put at that point, their foot is going to swell and balloon and be really uncomfortable. So we've really got to think about the bandage has to start from the most distal point. Same as what we do for hands, but it's so amazing how often I just see this middle of the calf bandage and I'm going, oh, I'm not sure what that's doing, but it's not being very helpful, and it wants to fall down all the time. And so this is an old skin cancer removal, I believe, and often we need to manage those. So that's actually healed now, but there's still a lot of swelling in that leg, and it needs to be moved on. Otherwise, I often describe it as that the fluid that, excuse me,
In our hospital.
the fluid that comes into the leg to try and help heal it, that gets stuck there, is very rich in protein. And the bugs that we don't necessarily want to grow in excess are really loving extra protein, and so they go smorgasbord, it's lovely here, and so they're more likely to tip it over into an infection or a cellulitis or some other version of not happy, which is then going to cause more fluid in, because there's a thing there being disruptive, and the body says, oh, let me send you some guys to help heal you. So have some more swelling, more swelling. Yeah. All right, so some more really nice pictures. Yeah, these are special. This is a burn here and here, and where they were grafted. So this is a long time after healed, but we can still see there's a lot of extra vascularity there, so they're pink. And so while they're not gone back to skin colour or paler than skin colour, we can work on those really actively. So I don't actually ever think we can stop working on scars. If they're adherent and stuck down, it's worth working on them, even if they're pale, because the structures around them are really happy to move with a bit of time. It just may take a lot longer. So the sooner we can get onto it, the better. But that one also needed compression garments in order to reduce the extra blood flow that was coming into the burn area. So yeah, this one was a particularly keen elderly gentleman that had no concept of his advanced age and clamoured around his shed to find something for a friend who needed something in his big shed, and managed to fall backwards despite never falling before. Yeah, right. Onto a piece of Rio bar, and so he's got multiple entry points, and thought that he might fix that with some ichthyol. You ever heard of ichthyol?
Is that black tie
Age,
stuff?
Old
black tie.
remedy, the black ointment stuff. But that didn't fix it. So then I wrangled him to fix it. That's a leg, that's the back of a calf. It took a long time. There was the...
Is this the final result?
No, that's
Oh,
a different one. Yeah, this one healed perfectly.
Wow.
Very resistant to compression, just cantankerous.
Oh, sorry, the wound wasn't resistant.
The wound wasn't, the person was. So we had to back off the compression and go with much lighter and much different things. So couldn't withstand a compression garment.
Wow.
Still can't.
Yes, interesting.
But in getting paled and put ichthyol on his wound.
Yeah. So there was actually an infection in here. I had to insist that the doctor send a slip to me so that I could take the swab, and we actually went around to some of the medical ladies near us and say, please can you give us a swab, because this isn't normally our job, but the doctor couldn't engage.
Yeah.
So it was really difficult, and so we didn't need a surgeon, we just needed a clean wound and looked after properly. So I think this may have been the really early days when we were making friends with microdicing. Microdicing is an excellent wound solution. I have no affiliation to microdicing.
I wish we did.
I wish we did, because we really, really love it, and it has been very helpful. So in the hospital, I often use Prompstan. Microdicing is just an alternative. Very, very good. So on just about every wound we see, we are washing it down with this rather than with saline now.
So it's a oxidized solution.
So it helps to debride the wound. So rather than me having to navigate and debride this with instruments, this will be really helpful at kind of loosening off the bits that need to come away. The other really important thing that my slide in a minute will talk about is that we want to debride things so that it is not just sitting there. That's never going to heal if this gobby stuff sits there and sits there and sits there. It has to be cleaned away in order for the skin to grow back properly. So, yeah, we really love it.
Shake photo.
No, I didn't do it.
This one, I can't remember the story behind it, but I think my main point is that red is not right.
Mm-hmm.
There's a certain level of red. It's not okay.
Ah.
And so you go, there's a vague pinkness about wounds and things, and you're kind of not worried about them. And then there's this other red,
Which is cellulitis.
often cellulitis,
Yeah. Right.
or that this margin you might be going, and that was not right. And there was in fact some nasty bugs growing in there.
So we've got an example of ulceration, then we've got an example of cellulitis, and then we've got an example of normal redness. That's just
normal redness
trauma.
and a healed skin that is a burn,
So we've got 3 sort of stages.
Different things, but things to look out for and watch and manage, and particularly as this was crossing a joint, this was really important to get compression on and not let it thicken and raise. So the longer it is that bright red scar tissue, the more likely it is to become hypertrophic, so raised and thickened, which then, keloid is actually very rare, so where the scar tissue grows outside of the margins of the wound, that's actually really rare, and it's more common with certain ethnicities.
Yes.
Yep. Yeah. So, but hypertrophic, so raised and thickened, is pretty common, and that's going to be a thing that will restrict movement, and we don't want that. And because restricted movement will be more likely to cause increased swelling. All right, this one is someone I have permission to share their slide, particularly because their story is quite unique. So this is amazing bruising from a motor vehicle accident. And bruising leads to scar tissue and adhesions, and this can block the lymphatic drainage. So what we need to do is manage the scar tissue and the adhesions to help regain those drainage pathways. So this here, yes, I believe so. So the seatbelt really caused. They were hit very hard from the day of stationary. The car that hit them was not, and she was the passenger. And so, unfortunately that she had this accident, and unfortunately that she had to know me before the accident, because this was a leg with lymphedema following cancer treatment. So she was already in compression garments. She knew that she needed to get them back on, and so her family member rung me from the remote location where the accident occurred and said, how do we manage this? And I said, well, you've probably got to get it back here, and I'm going to see you to sort this out, because the garment wouldn't go on, of course. But they did try. After a very few days, they managed to get it back on before they could see me, but the bruising was astounding. Did help. Arnica was quite helpful, because there was only broken skin. We could use arnica cream, lots of massage, lots of low-level laser therapy. But this, nevertheless, was an incredibly dinted band. So it was really an interesting thing. Has incredibly good control of the swelling now, and is all much better a couple of years on. So, yeah. Alright, so we're talking about healing the wound as soon as possible, use the most appropriate dressings for moist wound healing principles, continue until the scar is robust, and wounds should not be allowed to scab over. So it's one of my pet peeves is, oh, it was so close, oh now it's dry, look at that. And I go, yeah, but it's not healed. Because when that scab comes off, there's still an open area, and it won't heal properly if there's a scab in there. So we want to not let that go. We don't want them to be waterlogged, so that's really important. So, I don't know, do you have any favourite? Yeah, we don't want any maceration, so we want to use the most appropriate dressings to do the right level of sucking up of moisture, and each day, and changing as little as possible, but often enough to not have it macerated. So that's where the Clever Wound products are really important, because they have the capacity to do that. So, do you have any favourite wound?
I was just thinking, I do mostly surgical incisions, which are those narrow wounds, but and I don't want to throw this into the mix. I like the pico dressings and the suction dressings for the larger ones. Yeah. So there you go. We'll throw something else into the mix.
Yeah.
Would be difficult to access. Yeah.
That's right. So usually it's only when they're in hospital. Yeah. But it can be very, very good. So, and that's a sealed containment. So that's actually excellent. That's too. Yeah. So, some of our favourite dressings are the Supersorb dressings, the H and the P, and the Meflex Light Flex Border. And the thing is, for particularly we love the 4 centimetre by 5 centimetre Nervous Light Flex. It's just perfect.
Okay.
And Supersol G is a gel dressing that is very, very clever, and you put something else over the top of it. So where you need to soften, say, a yellowy exudate that's stuck, it helps do that. It gets in there and gobbles it up, and is very, very good at sucking up extra moisture. So it's a funny dressing if we, when we first demonstrated them by a rep, they poured a cup of water on this dressing, and it did what the gel stuff in nappies does, which is just do this, and that's what it does to the wound, is it sucks it up and locks it away so that it's not bathing the wound in moisture all the time. So clever. Yeah. There's lots of different dressings out there, so but we do want to make sure that we've cleaned and debrided the wounds, so it's vital so that they're able to grow in properly. A 10-minute soak with the microdicin is usually what we do. So either spray it and leave it sit, or tip a bit of the microdicin onto gauze and let it soak under that, and that works really well. And there's usually things we've got to be doing in that timeline. We might be prepping the splint, or we might be getting the bandages, or educating them about their exercises, and so it's not that hard. And then wiping it over with the gauze, which is good for just taking away lots. So I probably do much less instrument debridement now that we can basically spray that on and wipe it away.
Okay.
So that's easier. Otherwise, use sterile saline and gauze as the alternative, and sterile scissors and forceps to your right. We definitely want to keep the tension of scars and healed wounds. And so after having worked with plastic and reconstructive surgeons for a long time, one of their golden rules was for 6 weeks after healing, keep the tape on. So we put micropore tape on. So nothing really fancy, it's just boring old micropore. And
it's fixable.
Same dip, yeah.
To flatten the scar.
For keeping the tension off the scar. So if we imagine the scar's in under the centre here, so we tape along the length of the scar, so that as, particularly on a bit that moves, it's just not going to widen. So the scars, once they're here,
this is for the keloids.
It
stops that.
Well,
you've got to stick with it for the 6 weeks though, don't
yes,
you?
and you've got to be careful that your skin's not reacting. So my skin reacts to the tape after a number of days. So then I'll put Cavalon on first as a barrier cream, so it sticks to the Cavalon rather than to the skin. Or only the intermittent days where it's not on. We might then use silicone gel. There's lots of different versions of silicone gel, but we get it in sheets and cut it up to the right size, which can also help take the tension off. But I'd usually not start silicone until after I've got them doing massage, because otherwise their focus is on siliconing it and not massaging, which is just as important, or really important, particularly on the hand.
So the sticker care.
So thicker than that, it doesn't have the backing. But that one's the same gel smart, much cheaper. So in COVID times, I had to make a handout, which was actually really good, because I couldn't show people the. So I have a great handout on scar massage, and I have a nice model to demonstrate on. So here's one I prepared earlier. So what we want to do sometimes is just do deep circles like this, and
does that work?
off
A fair way after injuries happened.
Yes. So what we don't want is skin that is anchored. So we want it to move the way it should move. So testing the other side, for example, and going, is that what it does there? Yep, we want it to move the same. Yeah. So then we might do 4 directions. So we're going gliding that way with the pressure through the whole fingertips, and no oils or gels while we're massaging. We do the moisturising later, like you put the icing on the cake last. So we're mixing up the cake, and then we put the icing on later. So that's 4 different directionals, multi-directional barrier releases, and then we might do pinch and roll. So some bits of skin don't do that. So the soles of your feet don't pinch to get it. It's thick and it's special skin. But arms are meant to do that. So if I check, yes, that's what you're meant to do, so this is what you're meant to do. And so this one barely gives me any trouble now because I've done such good work on it and in fact had to restrain myself because I just really wanted to get over there.
Kerry scar.
So the other thing we will often do, because what we know is that when the scars are adherent and stuck and there's little cobwebs anchoring everything down, the lymphatic fluid won't move through that area properly. So we want to move that scar so that the lymphatic flow can improve. In fact, we usually assume that the lymphatic flow will never go through that area properly again, and that you'll often need to divert it. So if the scar's here and I've got swelling here for some reason, I won't take it up there, I'll take it this side or that side.
Okay.
Yeah. So non-slip mat, just common non-slip mat that you might line your drawers with, is really good at helping early days. So some people are a bit anxious over handling a fresh looking scar. They can't see it, so they go, ooh, yeah, I'll do that, I'm brave.
Is that in mind?
Yeah. And so then once they get a bit braver, we might introduce the spiky ball that's got to be done at the right time and not too early. And so we might do that, or we might, so we can roll it up and down, or do it like I call this the orange juicer. But quite commonly we'll put it in a sock as a starting point to dumb it down, and it isn't anywhere as soft as me. So, yeah. Then we might use lymphatic, so we might use dynamic taping to help with the drainage, and so this is a really particular version that we might do with, I call this sort of the octopus version. So you cut the tape just something like that around the end, like this is the body, and cut it into 4, and then we break his legs. And there's something very rewarding about that. And so if we were wanting to just stay there, we were wanting to come up to drain this area, say from a distal radius fracture, then we want to think about it. We put the body of the tape where we want to drain to. So I know that the drainage pathway is to just above the elbow crease and then up into the axilla. And then we want to put the skin on stretch if we can, so we might not be able to do that if they've got an injury there, and then we want to lay the tape with no tension. So it's different to how we might otherwise use it.
Can you do it a bit higher so we can see?
Stand up.
Got it?
Yeah.
Okay, so we're just going to place that down, and then you've got to remember there's no tension at the start or at the end of any of the tapes, because otherwise that can cause blisters. Releasing that and just laying it. You can see I'm not doing any tension at all, and then patting it into place. This one's cool because it's got a little pattern to it. Looks a little bit like a tattoo. I don't want a tattoo, but I'm really happy to play with tattoos. And you can put a number of these on in order to do it in different
So
patterns.
you're aiming to splay it apart, or are you following
Yes.
the pathway? Or
No, we're just aiming to lay it down and have gaps. Now what we're aiming to do is then we've got to rub it or just hold it to get the adhesive to anchor, so I'm being a bit rough with mignon. And then what we want is that it will crinkle. So can we see how that crinkles? Yeah, so crinkles. And what the crinkles do is actually lift the skin to allow the fluid through underneath. So it's almost the opposite mechanism to compressive gum.
Yes, okay, understood.
Yeah. And how does that feel?
Very comfortable.
Most people really like it. I have found this really good, and I did finally find the slide I wanted, but I couldn't find it at the time, on a leg, like a really big leg that couldn't do a garment easily after a knee arthroscopy. And yeah, this was just an arthroscopy on a family member, and just a big leg anyway, and it just helped drain away. You could see it, and where often where it might bruise, you can see that where the tape has been, it's moved the fluid quicker. So you go, something's working
Yes, of
here.
course. You can demonstrate.
Yeah, so this is an example of, it was on the back of the hand, so we brought it up here, and the wrist was in flexion, and then as she moves the wrist back, it crinkles up. Yeah. Lymphatic drainage exercises at least twice a day can be good, so we want to move the rest of the fluid around. So these are ones that we would do with our lymphedema patients all the time. There's 5 of them. Essentially, there's breathing goes with it so that we're shunting the very deep vessels in. They've got to go back to the heart. So we breathe in and breathe out. Everyone, breathe in, breathe out. Everyone at home too, breathe in, breathe out. And then we do 5 at a time. And then breathe in, out here, and breathe out here. And breathe in, and breathe out. And you normally do them lying down, but you can do them sitting up. So then what we do would be to do a tiny little sit-up, or sucking of the belly button in kind of thing. So we're wanting to sort of shut this area down. And I always say, if you're really confused about the breathing versus the limb movement, just keep breathing. And anytime you're opening up the chest area, fill it up with air. And then anytime you're placing it down, breathe out. So it doesn't really matter about the breathing. So this one is where you're placing your hands just above the tummy button usually, just below the rib cage. You can do it lower down, but often you annoy the bladder, and that's not great if you're doing this first thing in the morning before you've gone to the loo. Breathing in, and the tummy lifts out, and breathing out, and pushing in and up. Breathing in, and belly lifts up, and then breathing out, and pushing in and up. That makes sense? So we're doing a little bit of moving, of zhuzhing of the fluid around, and then as much as possible, many people can do this really well and some people can't do this very well at all. Just bringing one leg in at a time, and that's when you breathe out, and then breathing in, and then breathing out, and breathing in. So that helps these nodes move on. Now, if it was a leg we were trying to drain, we might also do the nodes in deep circles in the groin. So just above the pants line on the body end of things. Yeah. And that can really help move things on. So the nodes need flushing through. So that helps just to flush things around, and then it's a plumbing exercise. Really, we wanting to move the fluid on from the most proximal areas before we try and move more on. And it's always stroking up towards the body, always stroking towards the body, but we might clear these pathways first. And then go on to this. So it's a bit more complex than that when we're doing it formally, but it doesn't really matter as long as you're heading in the right direction and always stroking up. Yeah. So that's retrograde massage, and we want to clear the proximal areas first and stroke towards the body. So just thinking about these main nodes of the groin and the axilla and in the supraclavicular fossa. So just in there, middle of the collarbone, doing massage there. I have a theory that we should work on these every night, so we flush this system, so when our brain wants to flush things out, it's got somewhere to go. And that there's some interesting research that talks about the importance of flushing our brain each night, and that happens when we sleep. So, okay, so we've talked about the benefits of mobilisation. It's really important to get all this diffusion of everything going around, the zhuzhing of, I don't even know how to spell that word, but you know, the zhuzhing of all the tissues doing the thing, and that's going to help tendons glide and nerves glide and do all the things that we know we need to do, and to get controlled stress on the scar formation so that it's stronger. So we know there's great benefit to moving the structures that have been repaired just the right amount at just the right time, so that they actually remodel along the lines of the forces that are going through them. So the scar tissue that's built up, the lymphatic fluid that's built up, is going to be moved on because we're asking it to do what it's meant to do. Does that make sense? So if we're asking it to do full-on tendon glide exercises, then it's going to learn how to do that. If we don't ask it to do that, it will say, oh, you want me to do this? Right, that's what I'll do. I'm really happy just to sit here. Yep. So we've talked about minimal bulk in your dressings. We want to be careful with what structures have been damaged so that they're not going to get further damaged by us moving them too early. I often talk about that the scar tissue is a bit like this quick-setting cement. You've got to keep it moving or it's going to go hard. And so this is the classic tendon gliding set. So we want to go into full extension. We want to go into platform, down into a straight fist, into a hook, and the hook is where we're flexing the DRP and the PRP, but extending or hyperextending the MCP joint. That's it. actually so right.
Stress is my fingers out.
And then in a full fist so that it's,
It's not easy.
yeah.
It's hard to teach.
And that, yeah, we always have a handout so that it can remember it, because otherwise they get home and go, I don't remember. And that we need to sometimes be really, really clear is, are we talking about doing this just, or I'm usually, unless the structures can't handle it, I'm wanting them to assist the movement, not just try and strain to do it. So unless that's not right for the injury.
Okay.
Yeah.
Assist.
Yeah. So lots of options for compression garments. So there's ready-made compression gloves. There's tube grip. There's compression sleeves. So one of the things is like I said, we talked about tube grip. Often an arm will be a size C or a D. You've got to be careful that it's not too tight. I'll often only cut it with a tiny snip in the side, not a big moon for the thumb, because otherwise it just gets too big. You need to make sure that it's not pulling distal to that area, so that if you've got this on the hand, rabies fractures are classic, they'll often shunt fluid to the fingers, and so then you actually need a glove on there or bandaging to start with. Sometimes it only needs one session of bandaging in order to get it down and managed, and then they're right in something else. So the way I think about tube grip is if the thing we're putting it on is tube shaped, like a pipe, then it's probably the right thing. But if it's more complex, like an ankle does not look in any way tube shaped. My calf certainly does not look tube shaped, therefore it needs something different to that. It needs a leg shaped thing, not a tube shaped thing. So we've talked about the 4-inch wrap. We've talked about this is a really, really young photo of Kerry. And we often do this whole hand bandaging and for post-op anything. Yeah,
Not just burns.
No, not just burns, but like Jupitrins, this will be what we put on, like tendon repairs, just about anything. We'll get this in the first few sessions in order to manage the swelling out of that area. Sometimes a little bit lower because we really want to move the fluid past there. Yeah. And there should really be no tension on the bandage as it's applied. So, yeah. I did use many.
Is that you in the photo?
Yeah, go to theatre with the surgeons I was working with, and I would occasionally get to do the post-procedural bandage. Yeah, perfect. Going to bandage is a whole different thing, and we would rarely use that on a hand, sometimes on legs, and so this has been a great thing. So here's some that off-cuts. They're quite expensive, so I don't play with them very often outside of patients. So this is the comfort layer, and it bonds onto itself, and then over the top of that goes the compression layer. So you can kind of see that there's 2 layers, and there's 2 different levels of compression with it, and there's very specific ways of putting it on.
Never seen it.
No, so we use this a lot with the lymphedema in the legs. Yeah, or full-on lymphedema in arms. So just give you a sense of, so that's what it kind of feels like once it's done. It's lovely. And so that's the firmer compression layer with the lighter, the firmer comfort layer, the fluffy layer, with the lighter compression layer, versus this one is the firmer compression layer. You can see there's lots more elastic threads to it, and a lot going to have more warmth to it. So it gives us lots of good options for controlling the pressure, particularly when we're starting out, say bandaging a leg after say a flap or something like that. We might go super light with these. And say the hospital here will often just do Coban. But I find we get much better results with the 2-layer, and the patients are usually happier with it. So it's interesting once they come from there and only had that, and then they say, well, I'm going to try this, is that okay? And and they say, oh, please do that again.
Okay.
So compression garment tips. So we've shown you a few of those different things. Measurements are vital, so I would discourage anyone being sent to a pharmacy to pick up a compression garment. The pharmacy assistant isn't necessarily trained in fitting or measuring or anything like that, so everyone needs to be measured properly at the right points and look at it on the box and see what the right size is. So we're sent to a therapist that knows how to do that. We need to determine the level of compression, so that it might be that we're wanting 15 to 20 millimetres of mercury pressure, and a garment is specifically designed to give that, or that it's 20 to 30 millimetres of mercury pressure, or it's 30 to 40, and so you get it wrong, and you've got to have too much pressure, or you're going to have too little pressure to manage it properly. So, yeah, we'll often need to determine the type of fabric or the weave of the fabric that is going to be most useful, and so I'll show you some of that. And you want to make very sure the client can keep the garment on, just to don the garment, and to doff, which means take it off. Because if you can't get your garment on, you will freak out and you will cut it off. So we did have a client with a custom-made compression garment for a very unusually shaped foot that, despite having been in compression for a long time, had a bit of a breakdown in the middle of the night, despite there being someone else there in the house that could have helped him. Took a pair of scissors to a $300 garment. Yeah, we kind of kicked ourselves a little bit because we thought we'd covered all the bases. It might not been our fault. Yeah. So this is an arm sleeve as an example. So would you like to bring your arm? And so we could do it like this, or we could decide to use a plastic bag as a slip because it's got an open end. And slide it on and slide it on. And I'll probably use a smaller. Yes. Yes, except wetsuits won't want to roll in this like rolls. So then I'm going to give you. So that shouldn't have done that. But when it doesn't go where you want it, rubber palmed gloves or non-slip gloves is really useful to help just whip it into shape and spread it evenly. So it's very important that there's no bunching up, no doubling over, and that it's measured to fit, which I'm going to pretend I did just before. So, what's that go like?
So smooth.
Yeah.
Really?
So some of my patients with neuropathic pain or pain system hypersensitivity do really well in compression garments because they've often got swelling all in their arm, and sometimes it really helps with the skin hypersensitivity because it is just this constant I'm here, I'm here, I'm here, and so it dumbs down the inputs of the breeze and clothes and all the things, and they will very quickly get out of them when they don't want to be in them anymore. You don't need to be in them, but it's very useful to have. So. The other really important thing to know how to do, because you will see people that come to you and have a compression garment, and I get really annoyed when they say, oh, but the physio couldn't help me put it back on because they didn't know how. So they do know how to use the donner. So this is a donning aid called an Easy As, and so to use it we need a firm surface, and we want to.
I can tip that down and help you.
Can you pop it up on the table?
Does that work?
Yeah, we've got the table on the screen.
Okay, so we will usually put our gloves on because it protects the garment and makes your rings not damage things, but also makes it a whole bunch easier to use. So I describe this as a smile. Yeah, smiley face. So we put the smile to our tummy on a hard surface, and then we have, this is a leg garment, and we have the heel to the bottom of the smile, drop it in, tip it over top. So we want to grab it down like that. We do not want to do this, otherwise you'll come back and see me for your sore thumbs. We want to hold it in with the thumbs beside the next unit and slide it down. And slide it down.
Okay.
And slide it down. Now I make that look pretty easy because I do it a lot. It is quite effortful. And then you have your leg.
You've got a foot. Oh my goodness. I don't know that I can get it up. Up high enough.
No. Stand up for me.
Stand up and do it.
Beautiful shoes. Point your toes and push in. Push, 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 and down. Good. And then sit down. And then we grab it from the bottom and just put your foot down.
Push against you.
Yeah. So So we can go there and we can flip it off. You see that little bruise there? They're gonna love this.
Got it.
It's possibly the right size. It may need to be a tiny bit firmer on you. So
Gorgeous. It doesn't take long, does it?
so that's easy, and I usually baggy it off at the toe end
Oh, yeah.
so that it's not kind of branching right down. There's no one's toes like that. How's that feel?
Perfect.
Yeah. Leg-shaped garment. Keeps on a leg-shaped thing much better than which is going to bunch and do nasty things. So to get it off, always make sure they know how to take it off. So with their gloves on, they'll often just do flip over. Always skinning the bunny, and I've never skinned the bunny, but I can imagine that's very good. So that is donning and doffing. So this is just little pictures of garments going on. Yeah. See. Then there's other things like compression wraps, which I haven't got any of today, but they are velcroed on over a liner and do an amazing job at reducing. So when we've got a difficult situation that we can't necessarily get them in often enough, or where they have a helper to get that and they're not able to get into a garment quickly, then the wrap can be very helpful. It's actually fairly hard to get wrong once you bench up. So, yeah. And this is a comfy rag, which is a whole other thing which you'd rarely use in an orthopaedic context, but is just useful to know about because it's very, very, very unusual. So this isn't a sleeve, and it is bumpy. And so on a stodgy, old, swampy, swollen thing, we often use these to act as a bit of a massager. And very, very comfortable, surprisingly, very, very comfortable. Yeah, so feel like that. They're really, really interesting. So it can be very, very useful. It can be the garment of choice for sleeping in, because it is easier to keep up because it is sort of stiff and wants to be straight, not whereas the garments like this can, if it's going past the knee, can want to crease in at the knee and things overnight, which can be a bit painful and annoying. Yeah, it's interesting. So there are other types of garments also that, just as an example, so that is the, yeah, this is what we call a circular knit. So it's a standard kind of what a stocking looks like, right? This is a flat knit. So it is made flat and then has a seam, so on. So there are other garments that are cut and sewn, like the lycra sleeve.
Yep.
You can do that with legs and arms as well. But that's just another version. So often, because that's sort of stiffer fabric feel, we use it for different things. More often the lymphedema or the lipedema for the flat knit. Just different options. So in summary, we want to start edema management as early as possible and continue until it is completely resolved. And I mean that as well, because if you kind of stop wearing the glove and it's not really quite gone, it's going to come back. Or it's going to get stuck that last little bit movingly. I want to refer for hand therapy or OT or physio, whatever the relevant thing is. Input if edema and stiffness is slow to resolve and the patient's struggling, or they just don't know what to do. Because really, we often find that they want to do the right thing, they just don't know what that is. So then they don't know what it is, therefore they don't do anything. Whereas if they just get a little bit of input, then they'll really consistently do what you need them to do and they'll get much better. And particularly referring if there's structures like bones, tendons, ligaments and nerves involved. And that we know that one of my favourite sayings is that knowledge is analgesic, so it's pain relieving to know what the hell's going on. To understand the system and what's going on stops their brain going for meaning on things and looking stuff up on Google. Yes. It may not be very helpful. So, and the therapists will often be the ones that have the time to really see them consistently. We're not saying that has to be the surgeon doing that, so they have great faith in what you're saying to them as well, but sometimes they just got to have it repeated. And yep, this is getting better, you're doing fine. You don't need to push this further, or like, hey, let's push this a little bit more now, the doctor says you're ready, or no, you're not ready yet, it's only 3 weeks, you've got to wait till 6 weeks to do that thing, but we can do this exercise in the meantime, so depending upon what's going on, So yeah, I said, here's the team. And feel free to email me, and don't bury your head in the sand.
Very good. Thank you so much, Kerry. That was wonderful again. Thanks for coming back this year and spot on time.
Oh,
You did
not bad.
so well. I wasn't sure.
No, I wasn't either.
And thanks for letting us have a feel of all. It's great to actually be in the room and have a feel of all the different products because they do feel quite distinctive. So thank you very much for bringing them along. And thanks for sharing your wisdom. Very grateful and we look forward to Minions Talk next year. Thank you.